Hello, you're welcome to my platform. I am Dr. Sandra and I am a surgeon. I hope you become aware and sensitized about the different surgical conditions. Today's video is about an enterovesical fistula. An enterovesical fistula is an abnormal connection between part of the intestine and the urinary bladder. This abnormal connection between a part of the intestine and the urinary bladder allows fecal matter and the bacteria to reach the urinary bladder. When the bacteria reaches the urinary bladder, it can cause a complication, that is an infection in the system that forms urine. And so the patients that have enterovesical fistulas will always present with features suggestive of urinary tract infection. Because patients of the enterovesical fistulas present with features of a urinary tract infection, this can be taken at a face value, and so the patients can be misdiagnosed for having just a simple uncomplicated urinary tract infection, obscuring the fact that there is something underlying that is causing these symptoms, and that is the enterovesical fistula. The uncomplicated urinary tract infections commonly occur in women, and these result from bacteria reaching the system that forms urine either through blood or from the outside of the body via the urethra, the small tube where urine passes as a person urinates. And they usually respond well to antibiotics. So the symptoms tend to resolve when the patient has been given antibiotics. However, in the setting of the enterovesical fistula, the symptoms of the urinary tract infection will be persistent and will in fact recur even after antibiotic administration. This is because the underlying cause has not yet been addressed, and there is going to still be an abnormal connection between the intestine and the urinary bladder. And this causes a constant supply of bacteria from the intestine into the urinary bladder. This is why these symptoms will be persistent and recurrent. It is also very important to know that women are more predisposed to the urinary tract infections than men. This is because women have a shorter urethra than the men. The urethra is that tube where the urine passes as someone urinates. So the women have a shorter urethra. That tube is shorter in women than in men. And the shorter the urethra, the shorter the distance the bacteria has to traverse in order to reach the system that forms urine. This is why women have a tendency of getting these infections more than the men, especially if the bacteria is coming from outside the body. So this means that if a man presents with features suggestive of a urinary tract infection, this should be a point of concern, because we don't expect men to have urinary tract infections because of the length of their urethra. And what you also have to remember is the enterovesical fistulas are common in men. So this means that if a man presents with features of the urinary tract infections, we have to look for the underlying cause. And in this context, we have to look for the enterovesical fistula. The individuals that are commonly affected by the enterovesical fistulas include men, especially those 50 years and above, individuals that underwent abdominal surgery and had unintentional damage to their organs, for example, the urinary bladder and the intestines, individuals that have diverticular disease. Diverticular disease, by the way, is a condition characterized by small pockets bulging out of the walls of the intestines. Individuals that have Crohn's disease. Crohn's disease is a condition characterized by swelling and irritation of the inner lining of the intestine, specifically the small intestine and the beginning of the large intestine. Also, individuals that have ulcerative colitis. Ulcerative colitis is a condition characterized by swelling and irritation of the large intestine. Also, individuals that have cancers, for example, cancer of the urinary bladder, cancers of the intestines, especially the colon, individuals that received radiotherapy to the intestines, individuals that sustained penetrating abdominal trauma, for example, from a gunshot wound or a stab wound, individuals that have had long-standing episodes of chronic appendicitis, as well as individuals that have tumors of the appendix. There is something I really want to emphasize about the enterovesical fistulas. These patients tend to stay sick for a long period of time. This is because this condition is usually misdiagnosed for the uncomplicated urinary tract infection, and so this can delay the right treatment approach. This is because it usually presents with features suggestive of a urinary tract infection, and when you think about it, it really does cause the complication of an infection in the system that forms urine. It is no wonder that it also presents with the features of the urinary tract infection. However, the only differentiator is that the symptoms of the urinary tract infection caused by the enterovesical fistulas are usually persistent and recurrent, even on conventional antibiotics. But the symptoms of the urinary tract infection as a result of, for example, the infection coming from the outside of the body, or maybe coming from another focus within the body, for example, the lungs, if a patient maybe had a pneumonia, those symptoms for the uncomplicated urinary tract infection tend to resolve on conventional antibiotics. But the symptoms of the urinary tract infection as a result of the enterovesical fistula, they don't go away. In fact, they recur even when the patient has been given antibiotics. So that is the difference between the symptoms that are caused by the enterovesical fistula and then the symptoms that are caused by the simple uncomplicated urinary tract infection. The other thing that can help us differentiate if the symptoms are coming from the enterovesical fistula or just from an uncomplicated urinary tract infection is asking some questions, especially probing to see if they have any underlying predisposing factors, for example, diverticular disease, Crohn's disease, cancer of the colon, cancer of the bladder, if they had any surgeries in the past, or if they had trauma to the abdomen, and also their gender, because this condition is common in men, especially men 50 years and above. The signs and symptoms of the enterovesical fistulas include long-standing recurrent symptoms of a urinary tract infection. For example, the frequency of urination, that is urinating more than 8 times in a day. Urgency, that is the inability to postpone urination. That means that if the patient wants to urinate, they cannot hold the urine for some time. They have to go to urinate there and then. If they don't, the urine can just come out. And also suprapubic pain, that is pain in this area just below the umbilicus. And these symptoms are also the symptoms of the uncomplicated urinary tract infection. That is why it is very easy for us to misdiagnose these patients, because this is exactly how the uncomplicated urinary tract infections also present. And the only differentiating marker is that the symptoms of the enterovesical fistula are long-standing and recurrent, while the symptoms of frequency, urgency, and suprapubic pain as a result of the uncomplicated urinary tract infection are short-lived. meaning the patient is going to have relief of symptoms after antibiotic therapy, which does not happen in the enterovesical fistula until a surgery has been done. The patients will also present with the governor syndrome. A governor syndrome is characterized by 4 presentations. For example, the patient will have frequency of urination, that is urinating more than 8 times in a day, suprapubic pain, that is you feel pain just below the umbilicus, that region of the abdomen just below the umbilicus. There will also be dysuria, that is pain on urination, as well as tenesmus. Tenesmus is a feeling of wanting to defecate, even when you don't have stool in your rectum to defecate. The patients will also present with 2 symptoms that are specific to the enterovesical fistula, and these include nematuria and fecoruria. Nematuria is when the patient passes out urine that has air bubbles, air and then froth. This air comes from the intestines and then it is passed out with the urine. The patients can also have the second symptom called fecoruria. Fecoruria is when the patient passes fecal matter in the urine, and this is because this fecal matter is coming from the intestines into the bladder and it is passed together with the urine. So if these symptoms are seen, we should not even be hesitant to diagnose the patient with the enterovesical fistula. The patients will also present with abdominal pain as well as systemic symptoms, for example, fevers, chills, nausea, vomiting, as well as low blood pressures. And once these systemic symptoms occur, it means that this patient is in danger. The bacteria is now in the blood, and this patient needs urgent admission in the hospital for monitoring and treatment. When it comes to the treatment of the enterovesical fistulas, it is always good to be on the lookout for patients that present with features suggestive of a urinary tract infection. This is because this condition presents with those features. So the patients that present with the features of the urinary tract infections, for example, frequency of urination, urgency of urination, suprapubic pain, are best divided into 2 groups. The first group is those patients that are coming with the first episode of the urinary tract symptoms, and then those patients that are having recurrent features of the urinary tract infections. For patients that are presenting with the first episode of the features of the urinary tract infection, we usually start with a urinalysis. So we take off a sample of their urine and we study it. If it is negative, we don't give any antibiotics, but we look out for other causes of these symptoms. If the urinalysis results are positive, we can go ahead and do a pelvic ultrasound scan. Remember that this condition is common in men, and we usually consider UTIs occurring in men as complicated cases. So we have to do an ultrasound scan of the pelvis to make sure that we don't have any underlying conditions that are causing this UTI. The pelvic ultrasound scan is meant to look out for any structural changes, for example, an enlarged prostate, any diverticulum are pockets, and in our context, we are looking out for the enterovesical fistula if there is a connection between the intestine and the bladder. If the pelvic ultrasound scan is positive of the structure changes, we can go ahead and do a CT scan or MRI. If the CT scan and MRI are positive of the structural changes, we can do a surgery. This can be done by the general surgeons or the urologists. And if the CT scan or the MRI are negative of the structural changes, we can just do a follow-up of this patient. The other thing that we can do for patients that have positive urinary cyst results is doing a culture and sensitivity. So we take off a sample of the urine and then we look out for the bacteria in the urine. And as we do that, the patient can be given the conventional empirical antibiotics, the ones that are used normally for the UTIs, as we wait for the culture and sensitivity results to come out. And after 48 hours after the results are out, we can change to the medications, the antibiotics that have shown to be able to kill this bacteria that was isolated in the urine. If these patients don't have the specific features of the enterovesical fistula, that is the nematuria, that is air or bubbles or froth in the urine, or fecaluria, that is fecal matter in the urine, we just stop at that. We only stop at antibiotics. But for patients that have the specific features of the enterovesical fistula, that is the nematuria, that is air bubbles and froth in the urine, or fecaluria, that is fecal matter in the urine, we have to go ahead and investigate them more with some tests. For example, the poppy seed test, where they are given some seeds, the poppy seeds, such that these seeds can be checked for in the urine. We can also do the methylene blue test, where we can infuse methylene blue into the rectum such that it can be investigated for in the urine. So we insert a catheter, and as this methylene blue infusion is put in the rectum and then into the intestine, we can look out for the presence of this solution in the catheter. And if it is there, we shall just conclude that there is a connection between the intestines and the bladder. And if these tests are positive, we shall just operate this patient. If the poppy seed test is or the methylene blue test is negative, we can do a CT scan or the MRI, looking out for structural changes, for example, the enterovesical fistula, diverticulum, or a tumor in the bladder. If the CT scan or the MRI are positive of structural changes, we can do a surgery to explore and see if there is any abnormality. Because remember, this patient had the specific features of the enterovesical fistula, even though they had a negative poppy test and a methylene blue test. And if it is negative for the structure changes, we can still go ahead and explore this patient, because remember, they had the specific features of the enterovesical fistula, that is the nematuria, that is air bubbles, air and froth, as well as fecaluria, that is fecal matter in the urine. You can please pause the video and take a screenshot of this image, as it is a summary of everything that I've talked about. For patients that fall into category 2, that is, they present with recurrent features of the urinary tract infections, we also start by doing a urinalysis. And if the urinalysis is positive, we can send a sample of urine for culture and sensitivity. Then the patient can be given the conventional empirical antibiotics that are known to cure the UTIs. And after about 48 hours, when the results of the culture and sensitivity have come back, we can switch to the medications that have shown to kill the bacteria as per the results of the culture and sensitivity. If the patient is very sick with systemic features, for example, fevers, nausea, vomiting, chills, and low blood pressure, the patient is best managed in an inpatient facility. So we should always admit these patients for proper monitoring and treatment. Still, for the patients that have a positive urinalysis, we can go ahead and do an ultrasound scan, looking out for any structural abnormalities. Those that exhibit structural abnormalities on ultrasound scan are best managed surgically. For patients that do not exhibit structural abnormalities on ultrasound scan, we can go ahead and do MRI or CT scan. If the MRI or the CT scan exhibits structural changes, these patients are best managed surgically. However, if the patients don't exhibit any structural changes on CT scan or MRI, we can just follow them up on antibiotics. Still, for the patients that have a positive urinalysis but don't have the specific features of the enterovesical fistula, that is the nematuria, and fecoluria, that is the air bubbles, air and then froth, as well as fecal matter in the urine, we just end there. We just give them antibiotics. There is no need of investigating them further. However, if they have the nematuria, the fecoluria, that is the air bubbles, the froth, the air, as well as the fecal matter in the urine, we have to continue with the investigations. So we do the POPC test and the methylene blue test. And if it is negative, they will follow this path of the ultrasound scan like we saw in the second example. But if the POPC and the methylene blue tests are positive, we shall just go ahead and operate this patient, because this is an indication that we have a connection between the intestine and the urinary bladder, a condition called enterovesical fistula. Once we have established that the patients have an enterovesical fistula, the next best step is a surgical intervention. We usually recommend surgery because we want to reduce the possibility of complications. Complications like septicemia. Septicemia is when the bacteria goes to the bloodstream and it can cause a reduction in the blood pressures. This can cause a reduction in the amount of blood that goes to the vital organs, for example, the kidneys, the heart, and the brain. And these organs will be deprived of oxygen and nutrients, and so they'll shut down, and the patients can easily lose their lives. The surgery that we carry out is called resection and anastomosis plus bladder repair. Resection and anastomosis means that we cut away the portion of the intestine that has the fistula, and then we can join the two ends that have been left with sutures. Then we can also do bladder repair, that is that area where the fistula is connecting to the bladder is also repaired such that the hole in the bladder is closed off. The take-home message is enterovesical fistulas can easily be misdiagnosed for uncomplicated urinary tract infections. This is because inherently they cause infection in the system that forms urine, and so they will present with some features of frequency, urgency, and suprapubic pain, just like the uncomplicated urinary tract infection. However, the urinary tract symptoms of the enterovesical fistula are going to be persistent and recurrent even on antibiotic therapy. which does not happen in the symptoms as a result of the uncomplicated urinary tract infections. Therefore, if you happen to develop recurrent symptoms of frequency, urgency, suprapubic pain like I explained them before, please show up to the hospital for proper assessment, investigations and subsequent surgical intervention, because there is a possibility that you have the enterovesical fistula and these symptoms are going to persist and will recur until a surgical intervention has been done. That is what I had for you. Thank you so much for listening to me. Please share my videos and also subscribe. See you in my next video. Bye.